We're going to get started now with our keynote lecture. It is my honor and pleasure to introduce Dr. Nanette Wenger. She is the professor of medicine within our division of cardiology and a consultant to the Emory Heart and Vascular Center. She is also the founding consultant of the Emory Women's Heart Center. She has a long and distinguished clinical and research background in cardiology, which I'm going to discuss further. She served as the chair for the U.S. National Heart, Lung, Blood Institute Conference on Cardiovascular Health and Disease in Women. She also chaired the World Health Organization Expert Committee on Rehabilitation After Cardiovascular Disease. She is the past president of the Society of Geriatric Cardiology and was the editor-in-chief of the American Journal of Geriatric Cardiology for over 15 years. She has received numerous awards, including the Gold Heart Award, the highest award that is given out by the American Heart Association, the Emory Williams Distinguished Teaching Award, several Lifetime Achievement Awards, including one from the Georgia chapter of the American College of Cardiology in 2009, then from the National Organization, the American College of Cardiology, just this year, and then also a Lifetime Achievement Award from the World Health Federation. She has had several mentoring awards, including the inaugural Distinguished Mentor Award from the ACC and the Eugene Braunwald Academic Mentoring Award from the American Heart Association in 2020. She was elected as a member of Emory's 175 history makers during Emory's first 175 years. And the American Society of Preventive Cardiology honored Dr. Wenger by naming an annual Nanette K. Wenger Distinguished Lecture after her, focusing on cardiovascular prevention in women. She has authored over 1,700 scientific and review articles and book chapters. She serves on editorial boards of numerous professional journals and is a sought-after lecturer on issues related to cardiovascular disease in women, heart disease in the elderly, cardiac rehab, coronary artery disease prevention, and contemporary cardiac care. She has been a mentor to all of us here at Emory. We are very selfish with her, but she belongs to the cardiovascular community worldwide. And she's a great example of clinical excellence, dedication, and scholarly distinction. It is a great pleasure that I introduce our keynote speaker, Dr. Nanette K. Wenger, who will be giving a lecture today on cardiovascular disease in women, epidemiology, awareness, access, and delivery of equitable health care.
Igioma, that almost sounds like an obituary, but I assure you I am quite alive. And I'm really delighted to be able to share with this audience the work that the American Heart Association colleagues and I did on this issue of cardiovascular disease in women, talking about epidemiology, awareness, access, and delivery of equitable health care. My disclosures do not constitute a conflict. And what I'm going to do for each of these areas is to review for us some of the background information and then to highlight the knowledge gaps and the research needs. So anyone who is looking for research projects, here is your list to develop. Obviously, cardiovascular disease is a leading cause of mortality for women in this country. And you've heard briefly in many areas how research identified important biologic differences between women and men, but we haven't spent enough time on the responses to social, environmental, and behavioral stress. You've heard about the underrepresentation of women in all aspects of biologic research, and even when this was identified, a delay in the translation of these discoveries to the clinical care of women. Now, here is what I demanded in this paper that's referenced. We need a cultural shift when we present cardiovascular health data, because we identify the characteristics in men as an implicit gold standard, with the presentations in women called atypical. Those presentations are typical for women, so we must change the culture of our terminology. But obviously, the pervasive gaps in knowledge and care delivery require urgent attention to reduce sex-based disparities and to achieve equity. You've heard in all of the presentations information about these sex-based disparities. Now, the traditional risk factors are highly prevalent among women in this country, but we've not focused adequately on the racial and ethnic differences. And let me give you just a few examples. Hypertension is highest in non-Hispanic Black women. LDL-C is highest in non-Hispanic white women. Diabetes highest in Hispanic women. And note, in the literature, we use the term Hispanic. That is not a genetic determination, that's a language determination. And what I've started to do is to identify the specific populations. And in the data that I'm presenting, that Hispanic cohort was mostly Mexican American. Overweight and obesity, highest in non-Hispanic Black and Hispanic women. So women are not a homogeneous group. And the first cut being men and women, but then we have to realize the specific characteristics of subpopulations of women. Now, even though the traditional cardiovascular risk factors have a comparable prevalence in women and men, the control of hypertension, diabetes, and dyslipidemia in this country is suboptimal in both sexes. I think it's important to realize that smoking and elevation of systolic blood pressure are the first and second risk factors contributing to the years of life that are lost in our American population. Now, sex-specific risk factors, and these have only come out in very recent years. You know them: early menarche, premature menopause, PCOS, hypothalamic amenorrhea, hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, low or high birth weight, fetus, oral contraceptives, and menopausal hormone therapy. But where do these appear in our risk scores? And I'll come back and talk about risk scores in a moment. But what we are seeing that is a tragedy is we are seeing over the years a decrease in the cardiovascular health of pregestational and pregnant women, and that is a major contributor to the risk of adverse pregnancy outcomes, and not only for the women, but this is associated with decreased cardiovascular health in their children. So we are passing that burden to the next generation. Now, what about sex-predominant risk factors? And we're beginning to recognize these more prominently. The systemic inflammation and autoimmune disorders, lupus, rheumatoid arthritis, and scleroderma. Your woman patient with lupus will not die of her lupus. She will die of the cardiovascular complications. Depression and anxiety, more frequent in women, and particularly at younger age, and we'll come back to this burden in young women. Chemotherapies for cancer, and for women particularly so for breast cancer. And you know, it's so sad when I see a woman in my clinic and say, congratulations, your breast cancer is cured, but I'm sorry, you now have heart failure. We have to learn not to trade one illness for another. And I think we've not spoken enough about population attributable risk factors, because we need this metric if we're going to refine and prioritize public health measures. This is such a major illness, it is now a public health problem. Now, for white women, obesity and hypertension are the highest risk factors for heart failure. For Black women, there has been a temporal increase in diabetes as a risk factor for heart failure. And for Black women, hypertension and diabetes impart the greatest risk for heart failure. So we have to see where are the risks and what do they do in the different populations. Now, clinical cardiovascular disease and cardiovascular mortality. If we include hypertension as a cardiovascular disease, and it certainly is, nearly half of US women have some form of cardiovascular disease. This is an epidemic. There's an increased prevalence of coronary disease, heart failure, and stroke in non-Hispanic Black women. Women have increased ischemia with non-obstructive coronary disease. I'm not sure how much of this is microvascular, how much of it is vasospasm, and more myocardial infarction with non-obstructive disease. So this is a different pattern of disease, and we must learn about that disease if we must treat it appropriately. Women have increased spontaneous coronary artery dissection. Now, the stroke prevalence, even though it is comparable for women and men, with stroke, women have greater mortality and greater disability. You've heard about PAD in a very elegant lecture earlier today, but it is actually more common in women than in men. Significant base morbidity and mortality from PAD. But importantly, every paper identifies less therapy with evidence-based therapies. So the women are getting less evidence-based medical and interventional therapies. Now, total cardiovascular mortality decline is decelerating, both for women and men, in the past 4 decades. There was a sharp decline. It's leveling off and actually increasing in some populations. And the mortality from heart failure, despite all of our magic medications, is increasing. Whether we're going to see the magic pill of the SGLT2s change that is yet to be seen, but it shows promise. And relating to the lecture that Dr. Sarescu gave, some people have said that the SGLT2s are going to be the statins of this decade, doing magic. I hope they're right. Now let's talk about risk prediction and prevention. We do the quantitative risk assessment tools. We all have them. They're on our handhelds. Age, sex, race, total cholesterol, LDL, systolic pressure, antihypertensive therapy, diabetes, and smoking. And we use those for decision-making in the primary prevention of ASCVD. But are they really applicable to diverse racial and ethnic groups? The primary population base were white, middle-aged Caucasian men. Important social determinants of health are not captured in any of these. And for those of us who are interested in social determinants of health, there's something that I learned only very recently that I think is going to be very positive in this regard. The Joint Commission, as they come to accredit our hospitals, now requires that the electronic medical record include social determinants of health. Now, you know, you can tease it out from various parts of the EMR, but we need with our EMRs to be sure that they're in one finite area where they are easy to see. If we don't see them, we can't intervene. What about pregnancy-related factors in chronic inflammatory disease? They're not in these standard scores. Obviously, highly relevant for women. And then I find some concern with issues particularly germane to women. The risk enhancers, I was glad to see them listed, but risk enhancers suggest that these matter less, whereas for women, these may be their predominant risk factors. My message is we need to redo risk scores. we need to integrate women's specific risk factors in the various scores that we use day in and day out. Now, someone said, what do we do about preventive interventions? And what do you do for the woman identified as potentially at high cardiovascular risks? And the fact is that they're grounded in a healthy lifestyle. And these are the AHA's Life Simple 7. You're familiar with them: non-smoking, low BMI, physical activity, diet per guidelines, untreated total cholesterol under 200, untreated blood pressure under 120/80, and fasting glucose less than 100. That should be something that's checked at every patient, at every visit, and the intervention started. I told you I was going to come back to the young women. Cardiovascular health is poor in young women, defined as those 20 to age 44, overall, but particularly during pregnancy. Cardiovascular health is especially poor in non-Hispanic, Black, and Mexican women. And remember, these are the women with the high complications of pregnancy. Gestational hypertension increases cardiovascular risk in women. That's not in the risk scores. And something that I think needs our attention is that all of these disparities are enhanced with rurality. The rural communities do worse than the urban communities, and maternal mortality is highest in rural areas. And I think as we begin to look at issues in Georgia, that should affect us particularly. Preventive interventions have to reflect this intersectionality. We say, oh, this is great. More women met their physical activity goal in 2018 than they did 20 years ago. That's really great. But nearly half of the women don't meet the aerobic activity and muscle strengthening guidelines. We've begun to make the first steps. We're nowhere from getting there. And then there is a notable disparity in meeting the guidelines. And for these physical activity guidelines, 54% of non-Hispanic white women, 40% of non-Hispanic Black women, 43% of Hispanic women. Not the same. Messages have to go out differently to different subpopulations. And interestingly, the association of income with meeting physical activity guidelines is very consistent with the adherence by the social determinants of health. I think every time we see a patient, we need to address not only diagnosis and therapy, but within the therapy, what must be done about the social determinants of health. So what do I see as the knowledge gaps and the research needs in this regard? We have to develop and deploy risk calculators that incorporate sex-specific and sex-predominant risk factors. We need cross-disciplinary research in the social determinants of health to design interventions specifically to address the determinants. We have to define and implement cross-disciplinary interventions, and that is not solely within the strictly medical sphere. It involves communities, it involves health systems, business, urban developers, economic researchers. We need to get a public health community involvement. We have to adopt and implement those risk interventions that embrace intersectionality and cultural sensitivity, and importantly, adopt and implement a lifetime approach to risk management and prevention. We don't start thinking about risk at age 40. We start thinking about it much earlier, and we have to pay attention across the lifespan. Now, what about the awareness of cardiovascular disease in women? Since 2004, and that seems so long ago, we began educational and advocacy campaigns to raise awareness of cardiovascular disease in women. And with the AHA's campaign and the NHLBI's campaign In 2009, we increased that awareness from 30% to 56%. But what happened since 2009? In 2019, just 3 years ago, there was a study that showed a 74% decline in awareness that cardiovascular disease was the leading cause of death in women, and that lowered awareness was less among younger women, where we see the disease burden, among Hispanic and non-Hispanic Black women. And this survey in 2019, fewer women recognized common heart attack warning signs. And the recognition was least among younger women. So clearly, we have our work cut out for us. Not just our patients, but we need the education of health professionals in order to improve awareness about risk factors in women and indeed the course of cardiovascular disease in women. In a survey, 70% of postgraduate medical trainees reported no or minimal sex-based medical concepts. Knew that there were them, but didn't know what they were and what to do with them. 22% of primary care physicians and almost half of cardiologists feel well prepared to assess cardiovascular disease in women. What about the rest of the cardiologists? What about the rest of the primary care physicians? You heard about the advocacy of collaboration between OBGYN clinicians and cardiologists to improve care for women. But the fact of the matter is that the lack of awareness of pregnancy-related cardiovascular risks, health, and outcomes remains an ongoing problem. Essentially, what I've shown you is that the awareness data reveal that we have lost a decade of progress. We've gone backward from 2009 to 2019, and we have to find unique ways of catching up. We have to target our younger audiences through social media channels. We didn't have those really back in 2009, and we have to learn how to convey health messages. AHA has a Research Goes Red registry, which involves patients across the country, geographic distribution, rural, urban. And this is designed to achieve awareness, engagement, and scientific contributions and real-world partnerships between women and researchers. And this is an area that I think the research community has to utilize. So the knowledge gaps and the research needs, what do we have to do to remedy the decline in awareness among women that cardiovascular disease is their leading cause of death? And it has to be culturally sensitive for specific racial and ethnic groups. We have to educate healthcare professionals about specific intrinsic and extrinsic age-specific factors, recognize and treat women at risk across the lifespan for cardiovascular disease. Now, probably one of the major concerns, and that is the access to and delivery of equitable health care. And equal does not mean equitable. Equitable means that the outcomes are comparable. I've learned a lot doing research for the paper that we wrote. Access to affordable insurance coverage and out-of-pocket costs affect healthcare access and use for women. More than a fourth of the women in this country spend $2,000 or more on medical costs annually. And a third report skipping medical care due to cost. This should not happen in the US. The Patient Protection and Affordable Care Act, Obamacare, actually that provided the largest coverage gain for women aged 19 to 64. The women in this group benefited particularly from Obamacare. Percentage of uninsured women, 31% lower in 2018 than than it was much earlier, but it still remains unacceptably low. Medical expansion in the ACA has a beneficial effect on healthcare coverage and use in low-income women of reproductive age. We've identified them as a high-risk population. And I'm waiting to see the details of the legislation that just passed our Congress, which I think was I promised to be apolitical, but I think this was a very great accomplishment for healthcare in this country. The challenge is going to be in its implementation. Legislation is step one. The regulations and the implementation are where the rubber meets the road. I'm coming back to the rurality. Women in rural America are at greater cardiovascular risk than urban women. And what contributes to this? Less access and healthcare system delivery gives this additional risk. We all hear about the closure of rural hospitals. The increase in the life expectancy gaps between the rural and urban areas has increased in recent years. It was 0.4 in the 1970s. It was 2 years in 2009, and more recent data show that it's more than 2 years. So we are doing worse than was the case previously. And hospital and outpatient facility care, clinician supply, insurance cover, and public health infrastructure all differ between rural and urban America. And we saw this. It came to us very abruptly and on everyone's television during the COVID-19 pandemic. And we saw the effect on the healthcare systems and the disproportionately affected populations. Let's talk more about background information. Non-obstructive coronary arteries in the setting of myocardial infarction are more frequent in women compared with men. And that's a marked difference, 10% compared with 3%. Myocardial infarction mortality higher in women than men, especially at younger ages. But look at some of the other numbers. With an acute coronary syndrome, women under age 65, the non-Medicare population, have lower rates of door-to-balloon time, under 90 minutes. No treatment gap for the older women because coronary disease is inappropriately thought to be an old lady's disease. Physician recommendations for cardiac catheterization with the same clinical history, women and Black patients less likely to be referred to cardiac cath. Let's move from the coronary to other areas. What about the Get With the Guidelines heart failure registry? No major difference between women and men in the overall metrics. But interestingly, women were more likely to be treated in hospitals that had a higher proportion of Medicare, Medicaid dual eligibility, and those are the hospitals that have the poorer outcomes. With the same disease, women less likely to receive an ICD, and that's in every one of the studies. Women who have mechanically assisted circulatory support have greater mortality. Are these devices really designed for women who have smaller vessels, who have smaller hearts, who have smaller bodies? What about the Get With the Guidelines stroke registry? Women less likely with a stroke to be transported to the hospital by EMS, less likely to receive imaging within 25 minutes, less likely to receive lytic therapy within 2 hours. That's guideline-based therapy, less applied to women than men. And are we surprised that women were more likely to die within 30 days of a hospitalization for stroke? The knowledge gaps and research needs. What can we do to better assist women to overcome the medical cost barriers to delaying health care and delaying their use of prescription drugs? And what we have to do is how can we effectively change healthcare policy? These are policy issues. How can we improve the knowledge gap, education, and awareness of the healthcare professionals of female-specific and female-predominant risk factors? And actually, what was the role of the COVID pandemic, which in every study disproportionately affected women compared with their male peers? And what have been the effects and will be the longer-term effects of the increasing economic, social, and family demands on women during the still ongoing COVID pandemic? Then we're living in an age of technology. How can we best adopt technology to improve everything we do in the hospitals, the efficiency of operations, the patient flow, the discharge, the access to elective surgery? We are using ancient technologies, and surprisingly, we haven't improved the healthcare system. I think an important area that I've not seen addressed is we have to use the available standard nomenclature in order to harmonize data across studies. What we're seeing is that there is less statistical power for small numbers of studies with women, women within underrepresented groups. If we can pool studies by harmonizing the terminology, we will have increased statistical power to get results. I know I've perhaps said this inappropriately frequently, but it happens to be a passion of mine. Expand the use of SDOH indicators in the electronic health records to understand how external factors, environment, social, structural determinants of health, how do they modify risk over a lifetime? And then another concern of mine, the traditional approach that we've used as clinical scientists has been to look back to capture longitudinal data trends. That tells us what has happened. What we have to do is to incorporate a look-forward mechanism to sample the trends from large data sources as they are emerging to address increasing awareness. We have to look forward rather than backward. Now, this is the call to action of my colleagues from AHA, and I think this is something that we are all responsible for doing. We need culturally sensitive, with appropriate translation as needed, awareness campaigns to identify cardiovascular disease as the major health problem for women. We have to emphasize the benefits of prevention. Remember that 80 to 90% of cardiovascular disease is preventable. We have to emphasize the benefits of lifetime cardiovascular health optimization, Life's Simple 7. You know, one of my teachers in medical school was Bill Cannell of the Framingham Heart Study. And he said, you know, health professionals are reluctant to talk about lifestyle during their brief encounter with patients in the office because they're being paid for what their mother-in-laws would have told them for free. And I think what we have to do is in our practice to take back the mother-in-law role and talk about heart-healthy lifestyle. We need interdisciplinary collaboration between cardiologists, vascularologists, primary care, OBGYN, to improve the recognition of cardiovascular disease in women across the lifespan, implement holistic risk-reducing strategies, educate about the risk factors specific or predominant in women, and again, as I said earlier, use risk calculators with quantitative measures of risk for life course, which are different: childhood, adolescent, the OBGYN community, and the primary care community. We have to be advocates, to advocate for basic translational clinical population and implemental research on cardiovascular disease, stroke prevention and treatment in women of all ages. We have to focus on the under-resourced populations. I think there is a high reward opportunity for a lifelong improvement in cardiovascular health. For our basic scientists, we have to ensure that animal studies include female animals. You shouldn't be studying disease of women in male animals. We have to see that basic science and all the omic studies use and compare female and male single cell lines, stem cells, and organoids. And importantly, augment the participation of diverse population in clinical trials with increased participation at both ends of the sphere, the younger women and the older women. And when the clinicians leading clinical trials represent diversity, there will be more diversity in the population enrolled. And then we have to become public health advocates. We have to engage communities to optimize cardiovascular health. School-based programs can involve patients and empower families. We have to meet with underrepresented groups where they are in the community. We have to partner with communities of faith, barbershops, and other groups. You're all familiar with the data that in the barbershops that serve the Black men, that having pharmacists there improved blood pressure control. And this is the use of a community facility. We have to engage departments and schools of public health to integrate public health and primary care. Advocate for public policy and legislative intervention to focus on the social determinants of health. Healthy food access, safe spaces for physical activity, clean indoor and outdoor air, and access to high-quality care for prevention and treatment. And finally, a surveillance system for risk factors so we can assess the progress to know where we're going and provide feedback to the key stakeholders in this venture. We have to leverage innovative digital technology to capture metrics for prevention, for outcomes, for care delivery. And again, one of the major resources is AHA's Go Red. This essentially says that what we have to do to reduce the risks and burden of cardiovascular disease in women is to raise awareness, optimize prevention and clinical care, support research, engage communities, advocate, and monitor progress. And this is my challenge to you for the years to come, and I thank you for your attention.